welcome to this special World AIDS Day webinar, which also happens to be on Giving Tuesday. The one big lesson that we've learned from the AIDS pandemic is that collaboration and coordination at every level, aid agencies, governments, funders, and organizations working on the ground are essential to understand, to treat, prevent, and ultimately save millions of lives at risk from such a complex and dangerous virus as HIV is. And that's why tonight, in the spirit of collaboration, we're delighted as One-to-One Children's Fund to welcome, first of all, members and followers of our long-standing partner, PATA, Pediatric AIDS and Adolescent Treatment for Africa, a network of frontline health providers in more than 450 clinics and hospitals in Africa, working with more than 300,000 children and young people living with HIV. Through its forums and platforms for linking, learning, and projects, PATA is continually mobilizing and strengthening the network to improve pediatric and adolescent HIV prevention, treatment, care, and support. How? By sharing knowledge and promising practices and disseminating it all. And that disseminates across the whole network, and everyone is working to really best practice. Now, we're also delighted to welcome supporters of Africa Tikkun, and that's an organization with whom we have lots in common, our roots, our vision for vulnerable children, and our parallel work in healthcare and child development. Africa Tikkun support young people from early infancy all the way up to early adulthood and adolescence, and also with employment. And they have 5 centers of excellence in township communities in South Africa, which focus on educational and developmental needs, as well as health and psychosocial needs. And when COVID-19 struck in South Africa, Africa Tikkun was one of the first of the major food distributors in each of these townships. And they were there at scale, and they digitized their educational programs as well to be able to continue uninterrupted with educational services, and also the work they do in their townships during and post-COVID. So it's great to be able to mark this World AIDS Day alongside these 2 wonderful organizations. Great to have you with us. And joining me now is someone else that's very close to our hearts, One-to-One Ambassador Betty Kroger. Becky was one of the first children to benefit from our antiretroviral treatment program in Cape Town 18 years ago. And if anyone remembers our book, which is still available, More Hills to Climb, there's a whole center page or spread on Becky. And look at Becky when she was a youngster with her tongue out. And that's when we met Becky. So Becky, great to celebrate World AIDS Day with you. In many ways, your journey has become One-to-One's journey. It started with one child, and that child was you. So really, it's an emotional moment to have you with us. And let's just hear it from your perspective, what World AIDS Day means to you, and your story so far.
Thank you so much, David, and thank you for having me this evening. I would just like to say that, do you know what? It seems like such a long time ago now that like my journey with One-to-One began, but what an incredible journey it has been. And because of One-to-One, I am healthy, I am happy, I am working, and I do my thing. And for me, World AIDS Day will always be a day of remembrance, a day of me being in the children's home and going to a whole lot of funerals of my friends and coming out of that and just moving on. But I moved on to where I am today, to be as healthy as I am today, because One-to-One stepped in and provided the support, the medication that all of us children needed back then, and helped us thrive really. So for me now, World AIDS Day is about celebrating the fact that so many people are living healthily with HIV these days, but at the same time, not forgetting what has happened in the past.
Becky, that was wonderful to hear you, and you've become um, just more than a successful, thriving HIV patient, adolescent. You're an ambassador of One-to-One. You're also an ambassador for DFID.
Oh,
Uh,
yes,
yes,
yes, I did that.
you did that at the World AIDS Conference
Yep.
in Amsterdam. I remember that, and you've also won the Prime Minister's Points of Light Award.
Yes, we both did, David. We
you,
both did.
yeah. So,
And yeah, the reason for me doing all of this work is to basically give back to all of the people that have supported me over the years, but also to inspire a whole new generation of young people that are growing up with HIV, to have their voices heard, and to also for them to realize that HIV is not, um, it shouldn't be as stigmatized as it is, and also that they can open up and talk to so many people about their statuses and not feel ashamed about it.
yeah. And I know you went to visit our project at Kroger, where you started, where you had your treatment, and
Yes,
15 years later, or however long it was, the group that we have there of adolescents with different chronic diseases, and you and that has been really an eye opener completely for us. That and you met the people themselves, but they, for an HIV person in that group to be in a group with young people with other chronic diseases, whether it's renal or whether it's anorexia or whatever,
yep,
it takes away the any stigma that they
it
seem to
does.
feel. Yeah,
Yeah, the main thing I got out of being in that room with all of those inspirational young people was the fact that it didn't matter what kind of disease or anything that they had. It was about them being together and supporting each other
mm-hmm.
through whatever appointment they had, and they always had each other. And I think that group at Grooteskeer was just so amazing, because as a child at Grooteskeer many years before them, we didn't really have that group. We had each other in the children's home, but we didn't have anybody else that we didn't know anybody else that had other chronic health conditions. So for me to go back and see that the group is thriving, and that Grooteskeer has done so much for these young people has been amazing, really. And that's thanks to all the donors of One-to-One, really, for making this happen.
Yeah. Well, just wonderful, as I say, to have you with us and setting the scene for World AIDS Day, and for our webinar that's now following. And first up, we have Shaffiq and Lorraine. And as I said to you earlier, Becky, Shaffiq
Yes,
was there at the time that you were receiving treatment.
yes,
Shaffiq was
yeah,
uh, the brains behind some of the vision of Pata that we set up with Paul Roux at the time. And Shaffiq is now the chair of Pata, and but more importantly, he's the deputy chief of UNICEF's global HIV/AIDS program. But first and foremost, Shaffiq is the ultimate clinician, caring, and I really mean caring, for children living with HIV in New York and also in Mombasa and in Kenya, where he's from. He's an associate professor at NYU, and he's also, as I say, the current chair of Pata. And to add some serious trivia, um, Shaffiq for the Anglophiles. Shaffiq graduated in medicine from Oxford and Oriental Studies from Cambridge. So a true Renaissance man. Now, Lorraine is going to join Shaffiq in this conversation. Lorraine is Professor of Clinical and, and Health Psychology at UCL, London, University College. And Lorraine's a rock star in the HIV world and a leading thinker on mental health, gender, parenting, and child development. Her expertise on the cognitive impact on children in HIV families has led to the development of our One-to-Ones Bright Start program, which is successfully piloted in Crossroads, Cape Town. And with Lorraine's help, we're about to incorporate this early childhood play model in our mentor-mother becoming holistic care initiative in the rural Eastern Cape. So, right, so you've heard about Lorraine and Shaffiq. Let's get into the webinar. So we're heading worldwide now for 1.5 million deaths from COVID, unfortunately, this year. But thankfully, the vaccine cavalry is on the way. And more about that later, I'm sure, from Peter. But it's almost 40 years since HIV emerged, 38 years. And more than 30 million people have died from HIV. And today there are 40 million people living with HIV. So let me start with Shaffiq. How do we stop people dying? And is there a vaccine on the horizon?
Thanks, David, and thank you, Becky, for your wonderful words of encouragement and support to all of us. You know, it's true, we've forgotten about this other pandemic as we are in the midst of the current one. But those statistics are real. So many have lost their lives already. So many continue to struggle living with HIV, of course, in particular children, mothers and adolescents in sub-Saharan Africa, which is still the burden, where the burden of disease is greatest. You know, the vaccine story continues to perplex us, and there isn't, I have to say, a promising vaccine. There are probably good candidates that generate broadly neutralizing antibodies. And it's not for lack of trying. The last year for which we have data on this, which was in 2017, we spent about $900 million in the search for an HIV vaccine. That's very significant. It's not money wasted because the science has taught us so much about vaccinology, and indeed has probably contributed to the development that has occurred so rapidly of the COVID vaccines. But I've heard people say, well, if you can do it for COVID, why couldn't we do it for HIV? And the fact is that these are very different diseases, and HIV is particularly challenging to develop an immune response against that is effective in controlling it. Remember, our own bodies have difficulty controlling this from an immunological perspective. So it's very hard to create a vaccine that will do that effectively. But that doesn't mean that we have no hope. I mean, even the best vaccines for HIV that have been tested have generated something like a 30 or 40% efficacy. But if you look at prevention methodologies like PrEP, or even antiretroviral treatment among people who are living with HIV themselves, these are close to 100% effective at preventing HIV transmission. So I think we have the tools to prevent transmission of HIV, and new tools are emerging already. You know, a few years ago, there was only one drug that was approved for PrEP. Now we have two, and recently those who've been following the news will have heard that an injectable form of a drug now has been proven so effective that the trials were actually stopped early. So the prevention tools are there. There may not be vaccines. We still hope for a vaccine, but we can achieve extremely high efficacy for HIV prevention using both biomedical and the structural and social interventions that we have that form part of combination prevention. So I really think that, you know, there's hope on the horizon. And even at this time when we're in the global pandemic of COVID, let us not forget that the ambition of achieving a world without AIDS by 2030 is very much within our grasp if we keep focused on the ideas and the technologies that we have and just scale up implementation.
Thank you. And Lorraine, one of the big issues that you've been working on is the early development of children who are exposed to HIV and and their apparent cognitive deficits or potential deficits. And can you explain a little why this might be happening and how we can address it? You're on mute, Lorraine. Could you unmute yourself?
Okay. That's a huge question.
Yeah.
And I'll try and summarize it for you because it is a challenge. So we've noticed right through the pandemic that there are signs of cognitive delay. Very often it's mild and not all children will experience it, but enough that it's worrying. Now, could it be the virus itself? We know it crosses the blood-brain barrier. Could direct effect of the virus on development be an issue? Could it be the treatments? Could it be the drugs that they're exposed? We do know that there's something about drugs during pregnancy. We don't know. Or could it be something about the environment? Because if a child is born to a mother with HIV, the mother is positive. Is she ill? Is she distracted in parenting? Is the father HIV positive as well? And all the ramifications, living in stigma, gravitating to poverty, maybe unemployment, maybe illness. So it's unclear. But what it may well be is a little bit of all of those. What we can do about it, ideally, is prevent the HIV infection transmitted to the child. But the studies are also showing that children who are born HIV negative but exposed in utero to the virus, they themselves have less severe cognitive deficits than the children with HIV, but still they underperform the HIV unexposed, uninfected children in their environment. So it's a problem, and there are a few interventions available, and we need to adopt them with gusto.
Right, and the type of interventions we're talking about are early childhood educational toys and teaching parents how to play with their kids, basically.
Well, yeah, we did a systematic review looking at what are the evidence-based interventions, and there was a few, not many, because not many have been trialed, but we know very clearly that stimulation does affect children. And there's longitudinal studies like the Jamaica study that showed after 22 years, just improving stimulation in child environments can help. And some interesting computer-based cognitive rehearsal, they call it. And that's shown very effective, but that's intensive. And there's no way that we're going to have computerized one-to-one neurological interventions for children living in great poverty, say in the Eastern Cape or in rural Africa. So the toy intervention that we're trialing, we try to mimic and say, well, what is the essence of these interventions? And could we get low-cost toys and train the mothers? The mothers are there and very willing, they're eager to work. And train them in these play-related. So it's a bit of play education. It feels like play, but if it's done properly, it's actually a kind of borderline. So everyone has fun, but we'll have to see what it achieves. We're optimistic.
And Shaffiq, in your clinical practice, do you see this emerging? Around cognitive difficulties, learning difficulties?
Most definitely, and as Lorraine has highlighted, we don't really fully understand the multiple modalities by which this is occurring. Nutrition clearly has some part in it. We know that children who are malnourished develop cognitive impairments. But we also know that there is a critical period in a child's growth and development where interventions can make a huge difference. And some people talk now of the fourth 90. Those who are not familiar with this will perhaps benefit from being reminded that the first 90 is the so-called treatment testing 90, making sure that 90% of people living with HIV know their status. The second 90 is making sure that of those people identified, that they're actually accessing treatment and on treatment. The third 90 is that all of those individuals should be virologically suppressed, so they're getting optimal benefit. And the fourth 90 is this concept of comprehensive care, of taking care of the other business. And for kids, there could be no more important other business than their general health, well-being, nutrition, and development. And we know that nurturing care applied over the first 1,000 days from pregnancy into the child's second year of life makes a huge difference to children. We've already talked about some of those interventions, and they include stimulation and parenting skills. And recently, we've developed some thinking as to how this could be applied to an HIV context. We have kids living with HIV who are coming into clinics. We have mothers living with HIV who are bringing their uninfected children into clinics. There's an opportunity there to interact with those families and to impart the elements of nurturing care that can really help to optimize outcomes. So I think this is sort of a new frontier for us, but one that is critically important to undertake.
Right. So this is, this could be applied across other stressed and vulnerable circumstances for families. It doesn't have to be necessarily HIV.
Certainly.
Some of the general principles that you're talking about, but it is, it has been measured in terms of HIV exposed and unexposed, etc. Lorraine, what about this, parenting, which is all part of this, the attunement of the parent with the child, which is again a general, general issue that every mum and dad is aware of and needs to be aware of. Can parenting be taught? Can we teach people how to parent? And does it matter in the long run?
Yes. Well, we've got very good evidence that parenting can be taught. And why not? For example, people say, oh, well, that's a natural behavior, you just learn. Well, childbirth is natural, but we have all the resources. You don't just leave people out in the fields to give birth. We have hospitalization and interventions. So we could just leave parents to parent, but intervention, parenting skills really are shown to be fairly effective. We, in the COVID epidemic, right in a few days, we got together with UNICEF and WHO and USAID and developed some very basic parenting tips based on these evidence-based parenting programs. And they went viral, over 131 million downloads of these. And parenting online is very cost effective. If you look at these parenting programs, they probably would cost globally something like $14 per parent. And if you think of what we waste on all sorts of things, surely this could be a great investment.
Yeah, and where are the fathers in all of this?
Yeah, they've been neglected a lot, aren't they?
Sorry?
They're really neglected, aren't they? I'm a real fan of fathers. Our study on teens in South Africa, we looked at teen pregnancy and we asked the fathers, have you fathered a child? And although about 13% of the young women had been mothers, only 7 fathers in the whole study said that they were fathers. We're not doing well with fathers. We don't engage them. We don't encourage them. And when we do, they're very eager and they play a role. I think when we look at gender and gender studies, we often use that as a substitute word for women, but we really should look at men too. Men are important. Men should be brought into the clinics. Men should be involved in parenting programs. And children need their fathers as much as they need their mothers.
Well, Shaffiq, no better qualified person on this panel than you to tell us about fathers, the role of fathers, what you see out in the clinics in Kenya, whatever, and what you see in your household. And I'm surprised we haven't seen your little twins appear yet.
Well, yeah, they're being kept away. Lorraine, thank you for reminding us of the importance of fathers. I don't think I got it until I became a parent myself, actually, just how important my role was. I think you're right, Lorraine, that we've not been doing justice to the importance of the role, not just of fathers, but of men in general in the HIV response. Transmission mostly occurs between men and women in heterosexually acquired HIV. And while there's a huge focus on prevention of adolescent girls and young women and making sure that they have the skills that they need, I feel like we're missing a major punch if we're not also thinking about how you can re-educate men, how you can address some of the gender norms that contribute to the type of sexual violence in societies that fuels the transmission of HIV. And I know from my own experience in the early programs involving the prevention of mother-to-child transmission, that we saw by far the best outcomes when fathers were invited to come to the antenatal clinic with their partners. Now, this is something that is common to us in the developed world, but antenatal care is still very much seen as the woman's domain in many parts of the developing world. Men are not welcome in that space, and yet their involvement, their participation was critical to ensuring that women had good outcomes, not just in terms of, informing the husband or spouse that, his wife is living with HIV. That, of course, is one step, but an active engagement to make sure that mothers are following up properly, that they're not hiding their treatment from their families, and that their kids are being brought in for follow-up testing. Vast improvements when fathers were engaged. And we've also innovated around this. I think most people are familiar with the mothers to mothers model of peer support, where women living with HIV, often mothers living with HIV, are trained as experts to provide support and even in some cases medical care to their peers in the community. So, there's really a need for fathers to fathers as well. And we have experimented with some of these ideas. We know that they work, that if you find male champions within the community who are willing to take on this role, that they can be extremely effective. Men listen to other men, and there are well described social environments where men interact with each other and learn from each other, and the whole setup is designed to achieve that outcome. So we need to tap into some of those structures, some of those social constructs, and just up our game in terms of how we engage men. If you look at people on treatment, men have some of the worst outcomes, and men definitely have the worst access to testing and treatment. So there's a lot to do with men, not to say we should pull back on the importance of making sure pregnant women are treated and making sure that adolescent girls are protected, but we need to look at the other side of that coin as well.
Shaffiq, that was, I knew we would get a jewel there. Mentor fathers. We're into mentor mothers. Our next, we've got a vision now for mentor fathers. Last word quickly from Lorraine, because we're running a little late. Lorraine, what are the two key lessons that maybe we've learned from the AIDS pandemic that can be applied generally to for all of parents listening to this webinar, that can be applied in the time of COVID?
Oh, two is very hard to say. I think for me, the most important thing is paying attention to mental health. And I know I'm biased because that's my area, but it stands in the way of everything. And it's not all about vaccines and treatments. It's about how you're doing. And we know that mothers with mental health problems have worse outcomes with their children. We also know that they can benefit from interventions. And we know that COVID is going to bring along a tsunami of mental health problems, as not only the virus itself, not only the deaths and the bereavements. The second thing, if I was to be cautious, I would say when we had deaths with HIV and AIDS, the one thing that we saw was a mushrooming of orphanages at the time when we needed family care. And we don't know really why. We really do know that family care is much more a better environment for children. And I think for COVID, we have to be terribly aware that not only might parents die, but because of the age skew of who dies from COVID, those very grandparents who stepped in to look after the children may be the ones who are affected. We might find an emerging group of children who grew up with their grandparents and they're suffering a double loss. So I think we have to be terribly wary of not just preventing and vaccine and lockdown, but actually really grappling with people are dying, people are ill, people might have long-term COVID-related or long COVID symptoms, which affects their abilities to care and parent. We learned from HIV that a family lens was really important and a long-term lens was important. It's not a quick fix.
Right. Well, thank you both. We got a jewel from Shaffiq and a pearl or two from Lorraine. And really thank you both for being part of this World AIDS Day seminar.